Hi, so this is my fourth little video on blood pressures, and I think it will be the last. So I want to do a hypothetical case. Say it's an obstetric patient and they had a combined spinal epidural with consequent vasodilation, and the patient's post-op is hypotensive. And so it's a prescription of for IV fluids. Remember, IV fluids is the first intervention to correct blood pressure. Will increase the preload, stroke volume, cardiac output, and then the blood pressure. So let's hypothetically say that the patient is responsive to our IV fluids, and we're on the correct side of the Starling curve and not overloading this patient. Also, the anaesthetist has prescribed a background infusion of a vasopressor, which increases the afterload and therefore the blood pressure. And in this case, the prescription is for phenylephrine, which can be given through peripheral intravenous cannula. And we've set up 10 of phenylephrine in a 50 ml syringe, and we're running that at a low background infusion of 3 ml per hour. We have an arterial line in, and we're measuring the mean. We have a mean around 80 millimeters of mercury, and so that means that we're looking at this blood flow against mean arterial pressure graph. We're in that zone of autoregulation, and hopefully our important organs of hyperfusion, blood, the brain, heart and kidneys are well perfused. And so with that, I've come to the kidneys. Now, the kidneys are a very important organ relating to blood pressure, and that's because about a quarter of the blood circulation perfuses the kidney. So the average person has about 5 liters of blood going around in a minute, which means that in 1 minute about 1.25 liters of blood go through the kidneys. And if the kidneys are happy, they do what happy kidneys do, and that is produce urine. So if they produce urine, that also means the venous return of this blood will be less, preload will go down, and eventually up here, preload down, the blood pressure will go down. So hence we need maintenance fluid, and a maintenance fluid, let's say, are running. So what are a few other feedback mechanisms that our kidneys are doing well? Well, the output should be about 0.5 ml per kilogram per hour. So say our patient is 70 kilograms, then the output needs to be 35 mils per hour. We can look at the serum creatinine levels. So creatinine is a waste product of our muscles, for example, and it needs to be cleared by the kidneys. So if the creatine clearance is too low, that's usually below 60, and definitely below 30 if we deal with kidney failure, according to the textbooks. And we can also look at the blood urea nitrogen. So it's also not exclusively related to the kidneys, but if it's up, normally it's between 3 and 8. If it's up, then we could think that the kidneys are not working. So going back to the kidneys are an interesting organ because they have a large reserves. You may have heard of people can live with 1 kidney, and that's because about 50% of the kidney is a reserve. So if the kidneys are dying by 50%, you may not even know it. So there may be proper output, the creatinine clearance might be okay, the blood urea nitrogen might be okay, but it could be hurting. So therefore it's so important that we have this art line in, and hopefully particularly with a mean pressure of 80, we're perfusing these kidneys, and they're hunky-dory and they're A-okay. So there's a lot more going around in the body naturally around maintaining good blood pressure. There's natriuretic peptides released from the aortic arch and atrium. It's the hypothalamus, which works through the anterior pituitary with ACTH, and the posterior pituitary of ADH, which have the effects of aldosterone and ADH retaining sodium and therefore maintaining blood pressures. Natriuretic peptides actually cause sodium excretion, so they lower the blood pressure. And then, of course, there's the renin and angiotensinogen aldosterone system. So aldosterone retains sodium, but you may remember angiotensinogen needs to be converted by angiotensinogen converting enzyme, ACH, which is made in the lungs. And then angiotensin causes arteriolar vasoconstriction, which leads to an increased afterload and therefore blood pressure. And then there's baroreceptors that work in the brainstem, and they can increase respiration, they can increase the heart rate and the cardiac contractility. They can cause vasoconstriction in the arterioles, but also in the veins, and all of that leads to an increase in blood pressure. So, most important to remember is that we want to give maintenance fluid to have happy kidneys that produce urine. We want to be on the left side of the Frank Starling curve, so we're not overloading the patient. We want to make sure that our vasopressors combined with our IV fluids maintain a good mean arterial pressure, keeping our brain, hearts and kidneys healthy, and of course also the rest of our body. If we fear the kidneys are not working well, then we can look at running a blood test and looking at the fluid balance and urine output.